I was talking to the little girl, and I said, honey, what bothers you? She goes, my mom and dad crying all the time. I want to die now, so they stop crying.
What profoundly honest, right? Profound honesty and insight.
Oh, it was unbelievable.
And did you share that with the parents?
I did.
Hi, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Doreen Rardin. Welcome to the show, Doreen.
Thank you.
Doreen is a registered nurse. She's been doing nursing for many years. Spent a lot of years in the medical intensive care unit. And now you are the co-founder of Caring Hearts and Hands of Columbia, Missouri.
Correct.
Well, welcome to the show, Doreen.
Thank you.
I hear wonderful things about you and your program, and I'd love to hear all about it today.
Okay.
So let's talk about what got you interested in end-of-life care, hospice, palliative care, and engendered a shift from the MICU world to the end-of-life palliative care world.
Well, it was a personal experience. I had my older brother who had a massive stroke and a heart attack.
Oh.
And my family all lives in Michigan, so I was there. And they, I was kind of his durable power of attorney. By speaking with him, we didn't do anything permanent.
So you were close.
We were very close.
Yeah.
Yes, we were. So anyway, we go down there, and this was on a weekend, which everybody knows on weekends things are different in the hospital setting.
Yep.
First thing was his own doctor wasn't there. He wasn't on call that weekend. So we had somebody I didn't know. And I had worked at that hospital for several years before. And the physician who greeted us pretty much just told us that he had a significant brain injury and that he was not going to survive, or he was not going to survive in the state we want him to survive in. And so I told him that he has always told me that if this happens, he wanted to be taken off the vent. And he was on a balloon pump, all the stuff, and just wanted to die comfortably.
A balloon pump is a heart assist device.
Yes.
So he was in a bad way.
He was bad.
And it was told to you in a very cold, dry, blunt way.
Yep.
Oh.
So I told him what my brother wanted, and he said to me that he won't do that.
What?
Yes. And I said, why not? And he said, because in my culture, we do not believe in that, because that to us is killing the patient.
Now, had you drawn up papers?
No.
Okay. So I think that's, let's do one take-home message. You say, have these advanced directive done.
Definitely.
And it's always like, I'll do it tomorrow.
Yeah.
And I'll do it tomorrow. And it never gets done.
Right.
And then, God forbid, you're in this kind of situation. So that might have helped.
That definitely would have helped.
Okay.
But I just couldn't get him to sign it. He just was not like that. You know, he would tell you things, but he didn't
Your
want
brother?
To, yeah, didn't want to.
So you didn't have it, and this physician was a do everything you can.
Yep, definitely.
Okay.
So I said, well, you're fired.
Right.
I want another doctor.
You're allowed to do that.
Yes. And he was not very happy. Obviously tried to talk me out of it. But at noon, another doctor came on. So this doctor came in, and the first thing he said to me was, I believe in everything you want. I think it's the right thing to do.
Okay.
And I think you have the right to ask that. However, he said, I can't make and do it myself. He said, I can write orders, but you would have to be the one to withdraw the care, take him off the vent, take him off the balloon pump, which I was fine with because I worked at that hospital, so I knew how to do all the stuff.
Did you have privileges there as a nurse? I mean, you were
kind
employed.
Yeah.
You were a known entity.
And I worked in their ICU, so.
Okay.
And I had a sister-in-law who was a respiratory therapist, so I said, fine, we'll do it. I don't have any problem with it. So he stood guard outside the door while we removed everything. I told him what I wanted him on med-wise, for comfort and pain and breathing issues and stuff.
Sure.
And he did that. And then he told me that they had a palliative care room, which I had never heard of before.
Oh.
So he explained to me it was just a room for a dying person to have their entire family be able to stay with them. And it had a pull-out couch. It had a kitchen in it. It was beautiful. The nurse that we had was so accommodating and so compassionate. And it was always about, what do I need to do to make you guys comfort? What do you think I need to do to make your loved one more comfortable? So she was amazing. And then at shift change, we got the nurse from hell.
Nurse Ratchet, like they say.
Oh, yeah. Yeah. And she said, well, I'll tell you right off the bat, I'm not coming in here every hour or two like the previous nurse. I don't have time for that. And I don't have time to sit around and talk. And I said, you're fired.
I like you.
I'm not going to listen to that crap.
Right.
So we got another nurse. I told her I did not want them to give shots. I wanted them on a PCA. I told them what meds I wanted them on and so forth. And they did it. And I never saw that nurse, the rest of the time.
Huh.
So when I got back to Michigan, or Missouri, the thing that was really bothering me was, he had 10 brothers and sisters.
Oh, wow.
Plus kids and grandkids and stuff. So we had a lot of people there. I never got a chance to say goodbye to him. I was so busy trying to make time for everybody else to be able to say their goodbyes that he died before I could do that. And that bothered me so much when I got back. And I kept talking to my daughter saying, this is not right. This is not how this should go when people are dying. And then I'd say things like, how many times have we ever said to a patient that we're too busy right now, but...
Right.
I've done it. But when somebody said that to me when I needed pain medicine now, it didn't sit well at all. So it made me think about things we're doing thinking they're fine. They're not fine. And the way we address people about how do you talk about DNRs?
That's a do not resuscitate.
Correct. And how do you explain, end of life, how the progression is before they die? People don't want to hear that. And back then, doctors didn't talk about it.
So how long ago was that when you say
this
back
was
then?
in 1998.
1998. So not too long ago. It's not like in the 1800s or something. So the late 1900s, but still there was a lot to be desired. And your experience, let's just call it in a suboptimal environment, prompted you to get involved and maybe do it better yourself?
Correct. I started looking around RMICU about how things worked there, and I kept track of things they're saying that aren't right to say, how they're acting. When you have a conversation like that, you need to be sitting down and talking to somebody face to face.
Right, if they can.
Yeah.
If they're not tubed or something. Yeah. Right.
But if they're not tubed, you should be doing that for their loved ones.
Yeah. And in the ICU, folks, these are sick people.
Yes.
People are dying all the time. The reason they're in the ICU is because they're very sick.
That's right. And I saw a lot of doctors who would just simply go in, see what they want, and walk right back out. Never even asking if there were questions. So I kind of just kept track of all of that. And it was a lot more than what I thought. I looked at, and people hate you when you say this, but I looked at, did the hospital lose money on people when they're dying? Did they make money?
What's important? It's a capitalist society.
Well,
and
unfortunately, it is.
Hospitals have to pay the bills, too. They have payroll.
Yeah. And if I'm going to talk about having a whole department to fix that I can't get money for,
right,
you better have a way of showing them that you can make the money or save the money.
Right, or at least break even.
Yes.
Right.
Well, I figured I did a 6-month thing like that, and it ended up for every single person we had on palliative care, saved $7,000 to the hospital. Saved.
Well, administrators that'll perk up their ears.
Well, they didn't really.
It wasn't enough. Now, in the late 90s, when you were getting interested in this subject, did they have national organizations or best practices guidelines or anything like that?
Not really.
Not even then.
Palliative care wasn't really a thing yet in the United States. I mean,
Really?
yeah, not real. I mean, they had a couple. You had to be have a master's degree to even work in palliative care back then.
Oh my goodness. Okay.
So, and they didn't have. I mean, I looked for schools, and you had to go to a university, and it wasn't a palliative care program per se, but it was more of end of life.
Okay.
So, they taught more about symptoms and that kind of stuff. So I found a program in Canada, a 2-year program, and I took that, and I was able to do it here.
So you were able to do it remotely?
Yes.
Because
And I
the
did all my
internet was
clinics.
just so you had to dial up.
I know. It was strange, but
So
I
you-
learned so much. It
We
was
used to
amazing.
we used to call it a correspondence course or something like
something
that.
like
So
that.
you were able to take a 2-year course. In Canada, was it like any university I'd recognize?
It was from University of Edmonton.
Edmonton. So not even McGill or one of these big ones.
No.
So you did a 2-year course. And what did you end up with, a certificate or a degree? You got a certificate in
Which a lot of people didn't think it was worthwhile for here.
And what was the name of that certificate? End of life care, palliative care?
Oh gosh, I've forgotten. I don't remember.
Something like that. But it wasn't even a master's degree or something. It was a certificate of completion.
Yeah. And we did
Okay.
a lot. I mean, you did your basic, like pain and symptom management, symptoms. But we did things like relaxation techniques, integrative therapies, fads in healthcare on when you're working with end-of-life patients. So we had a lot of stuff in there that I had never seen before in a class. So it was an amazing class.
So it was very valuable to you.
It was extremely valuable to me.
So you
I
took
learned a lot.
You learned a lot. Now you have this certificate. Now, when is this? The early 2000s now?
No, this was still in 1989 or 1998.
98.
Yes.
So in the late 90s,
Yes.
you now had this certificate. You now had some knowledge.
So I I talked to my boss, and he said he didn't think that would ever happen.
Your boss, so you were still working as an ICU
Yes,
nurse,
yes,
registered nurse.
Yeah.
And there wasn't much interest.
No, because nobody's ever heard of it.
It's astounding. I mean, 1998 is not that long ago.
I know.
I could see maybe in the 1930s or something, and even in the late 90s,
I
this hadn't
can't
been well
remember one
established.
person that could tell me what palliative care meant.
I am amazed.
Well, I was shocked too. So, of course, then I ended up bringing all the information I had to Mike Shirk was was our CEO at the time.
Of the hospital you
Yes,
were working
yes.
at.
And
Okay.
I had a good relationship with Mike.
So you talked to the CEO of the hospital you were in.
And we made a deal. He said he would let me do a 6-month study and teach. And he laughed at me when I said this, and teach physicians about how to do palliative care. And I said, oh, bring it on.
Bring it on.
Bring it on.
That's
I'll
so
teach 'em.
important because, as you described, that doctor who was caring for your brother who's in a bad way was not equipped to share that with you and to work with you in this situation. He was just cut and dry, just do what he had to do, and let you all suffer what may, come what may.
Or, it's those little things like somebody wants a percentage. I had this with another physician. He gave a percentage, and after we were done talking with his
You mean
family,
a survival percentage or something, or
Yes.
Outcome percentages?
And I said, okay, what do you really believe that percentage is? And it was like 50 points different. I said, why did you tell them it was 50% when you're saying it's only 10%?
To what? To survive?
Yeah.
Or intact survival or something like
Yeah.
that? Okay.
And he said, because they won't want to hear that. I said, this is ridiculous. I said, you can't go do things like that. You're
Not in
lying
America.
to them.
Now, there's something interesting. I'm not
You're loud, sorry.
No, you're doing great. I understand. I could be wrong, but apparently in Japan, if you're elderly and you have cancer, they won't tell you.
Well, not only Japan. There's other places. That
Other
do
places,
that.
yeah. I bet you there's other places. You just don't tell them.
You can tell the family, a certain person of the family.
Yeah. And then you just don't tell the patient, and they have benign neglect or whatever you want to call it, the ostrich defense.
And I taught a class on cultures. We went through many cultures about end of
help me,
life
because
care.
I'm so ignorant. Tell me.
Well, like, for instance, we had a patient that the dad was dying, and the son came out and said, you cannot talk about this to him. You can't tell him that.
So what do you do? That's a difficult position to be in.
Well, then they appointed a person that I can talk to and tell everything. They make the decision what to let him know. So what I did was, I saw him before the doctor did, so I put a note on the chart. Do not tell the patient there is anything terminally wrong with them. Do not tell them they are dying. And what do you think he did?
The doctor told him he was dying.
Yeah. And I asked him about that later, too, and he said, this is America.
Right.
Have rights. And I'm going,
right.
This is a cultural issue. Has nothing to do with America. This is how they were raised. This is how they believe. You need to respect that.
And legally, can we? Is somebody going to come back and...
They certainly could.
I guess they could, but I guess the end of life here, they're probably going to pass away anyway. So who is really going to sue you, right?
Well, families.
Right. I mean, you got to realize that in medicine in America, you have to CYA. You have to cover your ass in many different fronts.
But I just found so many little things like that would happen. Like, we had one gentleman who was very, very, very nervous all the time. And
the patient.
And the doctor wanted to give him something for anxiety.
Okay.
And the patient said, absolutely not. I will not take it, blah, blah, blah. So the doctor ordered it anyway and told the nurses they weren't allowed to tell the patient what the med was. And I said, no way am I going to do that. In fact, I brought it up to our ethics committee.
Yeah, that's an ethics board
because I was on the ethics committee.
Item.
Yes, and so they talked to him about it. So he didn't do it again. So those are the little weird things that come up when you're trying to talk about something that they don't know a lot about.
You might not anticipate that kind of thing.
No, you don't.
All of a sudden, you've got a different culture, and your normal way of sharing and describing is not appropriate.
Mm-hmm. But the real interesting thing was, we had decided early on that we were going to train mandatory training for, like, all charge nurses, all social workers, all supervisors. And they wanted me to make sure we got the majority of physicians. And I kind of went, oh, my God, really?
So how many, talk about percentages, roughly what percentage of doctors did end up taking your course or your
75%.
Whoa! In a Midwest hospital with somewhat, let's say, generally conservative mindsets. Mm-hmm. So this wasn't San Francisco. You got 75% of the doctors in a Midwest hospital to sit for your information.
Right.
Were they appreciative? Do you remember?
Yes, they were very. But the thing, and this is what I used to tell Dr. Kennett, he said, how do you get so many people at this? And I said, well, number one, I asked them which day of the week they would like to come. Would they like to have dinner or not?
There you go. Doreen wasn't born yesterday.
Do they need CEUs or CMEs?
Yeah, right.
So I did all of that.
Deal. The CMEs are continuing medical education units and hours, and those are very valuable because we have to have 50 hours every 2 years.
And I even let them pick the topics, or two of the topics. We ended up doing symptom and pain management. We ended up doing communication. So important.
Oh, my goodness. Important. That's the foundation.
I did one on integrated therapies.
Okay.
And then we did one on spirituality.
Fantastic.
The one they liked the best was spirituality.
Wow. I'd love to talk about all those, but I want to follow the career path, the development path of Caring Hearts and Hands. And by the way, Caring Hearts and Hands is a physical house here in Columbia, Missouri.
1307 West Broadway.
1307 West Broadway. In Columbia, Main Street is Broadway.
That's right.
So I want to continue the arc here of how you got to Caring Hands and Hearts. So now you're teaching, you've brought this information, you've taken this course, you've brought this to the hospital, getting some traction. Is care improving now in the ICU or in the hospital?
Yeah. But all of that education was to get a palliative care consult service in the hospital.
And did you end up doing that?
Yes, I did.
So you did your 6 months, and the
Presented
CEO
that.
and the CEO of the hospital was impressed.
Yes, he was.
And then gave you the green light
Yep.
to start that.
Program.
What do they call service line?
Yeah,
nowadays?
service
there
line.
you go.
Yeah.
As it were. Yeah.
Yeah.
So then what happened with that?
It started off kind of rough.
Sure.
Interesting enough, I had more problems with the nurses accepting the palliative care
Interesting.
than the physicians. Yeah, I never thought that was going to happen.
So what kind of resistance would you meet?
Well, number one, the big thing with pain and symptom management is you have to treat pain and symptom management.
Right.
You don't just let it go. If their point is if they don't ask for it, they don't have it, they don't get anything.
Right.
One good instance, we had a lady from a nursing home who never spoke. You'd go in the room and she would be sitting here like this. Didn't say a word, nothing.
Huh.
So the nurses figured she was fine. Well, when I got there for a consult, I'm looking at this. She had a broken arm, she had a dislocated shoulder, she had a skull injury. So I brought these nurses in here and I said, "What is this?" I said, "Do you think you would have pain with a broken arm? Or a dislocated shoulder?"
Oh, bone
Or
pain's horrible.
Oh, it's awful. Well, yeah. I said, "Then why aren't you giving her pain medicine?" Well, she doesn't ask for it. Everybody can't ask for pain medicine.
And she was able to articulate? It wasn't that she was mute.
Correct. And I also said, "Did you call the nursing home and ask what her normal behavior is like?" No. Well, her normal behavior, she was crazy, wild, not sitting still and not moving.
Now, did you talk to this woman?
Yeah, I did.
And were you able to elicit, "Gee, I'm in so much pain, honey, I can't move, and I'm
I asked
suffering
her
here"?
to blink twice if she was in pain.
Yeah.
And that's what I told the girls to ask.
And she was able to
Specifically.
communicate that way.
Mhm.
So you got some pain meds going,
Oh, yes.
and she did better?
She did better. She died, but that was,
Right.
we know that was going to happen.
Right.
But she was comfortable. You know, she was getting a little wilder, and she was kind of listening to music, bopping around,
Yeah.
you know.
So I'm going to jump ahead on an
Okay.
important topic here. It would be easy to get to assume the attitude that, hey, this person's near death. What difference does it make, right? But if you logically extend that, well, maybe you have a day, maybe you have a week, maybe you have a year, maybe you have 100 years, right? What difference does it make? And it comes down to, what is the value of life and the meaning of life? And for me, it comes down to the moment, you know, the infinite now. And that's the whole essence of life, right? What good is it to live 1,000 years if you're not enjoying
That's
the
right.
moment, right?
I agree.
So it's easy to, it's called reductio ad absurdum. You just make something so small, it's an absurd reduction, and it's meaningless. So I think we need to resist this tendency to say, hey, they're about to die anyway, what difference does it make? And really come into the now and the value and the meaning of life and being in the moment, you know? And you have to be in the moment with these people. And we're going to get to the 3 C's, and the 3 C's are comfort, communication, and coordination. And that communication with somebody. And while I'm going out of turn here, I'll just complete the thought here. You're not just giving to them, they're giving to you. And it's incredibly meaningful and powerful to the caregivers. It's not an energy suck. It's an energy share, isn't it? So anyway, I just had to, and I'm getting all choked up thinking about it because it really comes down to the meaning of life and what gives meaning and purpose, and why are we here, and what can you do to help others and draw value to your own life. So anyway, so I went on a tangent.
That's
here.
all right.
So now you're teaching this course, and then when did you come up with the idea to co-found a separate?
Well, during that 20 years in palliative care, I had found this place in Oklahoma called Clare House.
Clear House?
Clare House.
Clare House.
It's in Tulsa. And it was the first non-medical hospice house.
Like in the country? Or in the Midwest? Or
No,
one of the
anywhere.
Anywhere.
Right.
In Oklahoma.
Yes.
In the late 90s or the early 2000s.
Oh, well, she had started it earlier than that.
Okay.
Because she's been at it now for, 30-some years.
All right. So there was an established hospice in Oklahoma.
Well, it's not a hospice. It's a social model, end of life.
Okay, it's a distinction with a difference.
It is. And I say this because in Oklahoma, they call it hospice. But here, people don't understand the difference of what is hospice and what is palliative care or end-of-life care.
Okay.
When you say hospice, they think, oh, they're dying right now. And they think that when they have hospice at home, hospice comes, spends 24 hours a day with you. They had a lot of misconceptions about what hospice is.
Well, I hope you're going to clear those up for us today.
Yeah, we did.
And you will.
Yes. One of the reasons when we built this non-medical model is we provide the home, the physical house.
Okay.
We provide the caregivers. Hospice, they have to have a hospice to get in. Hospice then takes care of anything medical. Dressing changes, getting the meds, getting the doctor orders, anything that's medical, we don't do.
And the hospice here, would that come from our local hospital or
Yes.
social work or
It can be the family can do it. They can call up and try to get on hospice. But most of them come from social workers
Okay.
or physicians.
All right. But I'm just trying to figure that like the line here is coming from, if it's medical, clearly there's a physician or somebody writing orders and approving drugs.
And we don't want all of that. We didn't want the responsibility of that. That was the whole point, to show that medical hospice is what you get when you go to hospice. Just hospice alone.
But if you go to Caring Hearts and Hands, you get a safe place,
yes.
a non-medical model that draws in medical care like when appropriate. So you could be there and not necessarily have, I assume everybody's got a doctor or something.
Well, they do, but when they come there, they don't have, the doctors don't see them anymore. I mean, they can call them and get orders, of course, but
they don't have to, but you can take care of most of what's going on in this social model, you're calling it.
See, our mission is to provide a home, a comfortable home that meets the emotional, physical, and spiritual needs of our guests and their families, and provide caregiving 24 hours a day.
Well, there's a mission statement, perfectly said. Okay, so now I understand. So how did this home get off the ground? So now we're looking at what, 2010, 2020? Give me more of a timeline now.
We opened our doors last year in May. So we just had our first anniversary.
Oh, I'm so glad we're having this conversation because I want people to know about you.
Again, one of our biggest problems was we had 2 years we couldn't go out and teach people things.
Why?
Because of COVID.
Oh,
nobody would let you in.
Another victim, a collateral damage of the COVID epidemic.
Yes.
So when were you starting to have talks to co-found this project? Around 2018 were you starting to?
That was when we had our very first meeting.
You and one other person or a group of other
No,
people?
we made a list of who we would like to be on our board.
So you already had a plan to have
Yeah.
a board,
And
a
so we
governing
invited
body.
all of them.
In 2018-ish.
Mm-hmm.
And so you started to come together and you said, hey, we could make this work. So I assume you came up with a business model. Now, how do you fund this? A house, there's going to be a mortgage, there's going to be bills, there's going to be utilities, there's going to be staff.
One of the big issues I noticed also from families was financial. It was a huge issue. So one of the things I wanted to do was not charge them.
Did you bring in Mother Teresa here and nuns to be volunteer? How can you do this without charging?
We do a lot of fundraising.
I still don't see how you could start this project assuming you're going to rely on the generosity of people.
Well, Columbia has people. It's a pretty little wealthy town. It was difficult at first, I'll tell you, because number one, people didn't understand it. It was so hard for people to get the concept of what we were doing.
Okay.
Trying to find where we can have this house. Now, one of the other things we didn't want to do was get involved with Medicare and insurance and all that kind of stuff.
Oh, a nightmare when you get the government involved.
So
the
we
red
didn't want to
tape.
do that. And that was another reason we had hospice separate, but that they had to be on hospice.
Yeah, because if it's a program through the hospital, then Medicare, the whole deal, what is it called? I don't even want to come up with all the initials, the government initials.
Oh,
but it's all inspected and supervised.
Right. So we didn't want that.
Right.
I knew it was going to be difficult, but I knew we could do it.
But was part of your model that the clients, the
Yes.
the guests, well, I love it, that the guests would pay?
No. We never had that as a plan. It was always going to be free.
Well, I am just amazed that you could even get off the ground with that type of business model. But you did, huh?
We did.
Where did you get the funding? Just from generous patrons?
Well, we did a lot of talking, like I said.
Sure.
We went to pretty much every church. We had fundraisers. This year we're having our fourth Lights of Love, where we have
Lights of Love.
Lights of Love, and it's going to be at Cosmo Bethel Park, October 5.
So the house you're in right now, the physical plant, is that, if I'm allowed to ask, did you purchase it? Do you rent it?
We're leasing it right now.
You lease
with
it?
The plan to buy it in 5 years.
From a private individual?
We had a person that was running I can't remember what the name of it was now, but it was a home for teenage mothers, new mothers and their kids.
And that didn't work, or they moved somewhere else?
They needed a bigger place.
They need a bigger place.
I mean, it really was perfect. The thought that we found him, and he was so generous. He gave us the person that owned the other house.
The owner of the house.
We got the first year rent-free.
Oh, that's a benefactor.
Oh, my God.
Oh, my
He
goodness.
was so amazing. Because there were a few things we had to do to get this house coded-wise, you know.
Oh, yeah.
And they were pretty expensive items.
I run a business. I know there's a money suck everywhere.
Oh, my God.
And just when you think you got it right, the toilet's going to back up.
And it always seemed to be that way. Like the end of the year, it's like, are we going to have enough money for next year? We wanted to have everybody was a volunteer. We didn't want to have to pay anybody to do this. However, in this day and age, that didn't work.
Oh, they got to put gas in the car to drive to you.
Exactly right. We had enough, pretty much enough caregivers for the day and the first part of the evening. But weekends and nights.
So you have people 24 hours a day in this house.
Mm-hmm.
And I'm amazed you got this off the ground, Doreen.
Well, everybody says that. I said, but when there's a will, there's a way to do it. Well,
and a big heart. My goodness, what a will. I'm friends with a gentleman who's, I guess, chairman of the board of the Humane Society, and I'm aware of all the things to get a new place, to get the fundraising. It's no small feat.
No.
So you were able to get this off the ground. So you had a year of free rent, and you're somehow able to fix the building up to code, and you found volunteers and enough money to pay a night shift. So how
And
many
weekends.
So how many guests are now in the house, or how many can you hold? Or?
The law says we can only have 2 people.
2.
2. 2 people that are not family.
I was thinking like a dozen or 2.
2.
Well, then you must be full, because the need
much.
for this service is must be hundreds of people, I would say.
Yeah, pretty much.
Because there's 500,000 people within an hour of here. 2.
Yeah.
I assume you have 2 guests right now.
Yeah.
I assume that as soon as and does someone stay until they pass on?
Now, here comes in like, okay, what are the qualifications you need to be able to get in the house? Number 1, you have to be a DNR.
Do not resuscitate.
Yes.
Meaning you've made the decision. When God takes me, I'm going.
Yes.
Okay.
They can't have any IVs. We don't do IVs. We don't do shots. Everything we give is oral or rectal.
Okay. Okay.
So they can't be a diabetic and want, insulin shots. They can't have that.
Okay.
They have to have, one problem we found was people who are homeless. We're constantly getting asked for that. But because they don't have a home, hospice wouldn't take them.
Interesting.
So what we've done a couple times is got them in and then got a hospice after we got them in. Because then they have an address.
Oh. You're one of those ironies. You can't, where do you get your mail if you don't have a house? But how do you get a house unless you have a mail? Unless you have, at the motor vehicles. It's kind of interesting. They want a piece of mail sometimes with your name on it.
I know. It's
as an ID. It's kind of interesting.
because you have to have a home.
I got a passport. No, I need a government communication with your address on it that I could afford. A utility that I could afford surely easily.
Right.
One of these ironies of modern lives. All right, so you have 2 people. So I was thinking you had like a couple dozen guests. All right, 2 sounds much more manageable.
Well, and it was okay, I said, for the first year or 2 because we're so new and there's one other hospice, end-of-life home in Joplin.
That's about 4 hours away,
yes,
folks. That's
correct.
the other side of the state.
But that's the only 2 in the whole state.
Oh.
There are about, if I remember correct, 63 homes in the United States.
In the United States?
63.
In 50 states, there's 63 homes.
Yes. But there's probably, I'd say, a good 50 in process of getting the house up.
Okay. Now, when I see hospice care coming out of the hospital, the hospital here, there's even a satellite office, I believe, called hospice up north of the highway. How is that? Is that funded with Medicare money and state money and insurance money and all that kind of stuff? And that involves the caregivers going to people's homes.
Correct.
The word shelter in place kind of comes to mind here for some reason. So there is hospice type care, but it's not at your social model group home called Caring Hearts and Hands in Columbia.
Correct.
Now, I have a little experience with this. Both my parents were elderly, and I moved them here to the Midwest to be close to us, and they passed here close to us. It was talking about meaningful. And we had some wonderful hospice care in their home. They brought in a hospital bed, and a nurse would come, and they'd have narcotics and whatnot. And I remember when my mom passed, the the nurse came and took the narcotics and mixed it in kitty litter, the kitty litter trick. And then it was a whole system
It is.
set up, and it was tremendously valuable.
But family was the one who had to give the meds. And they did 98% of the work. It's not hospice.
Interesting. Yes. So I'll just share a little more. My parents had some retirement money. We knew they were passing away. And it was this race to the end. Are they going to have enough money for care and whatnot? Or are they going to run out of money before they die? What a horrible situation.
Yeah.
So thank goodness they had enough money that we were able to pay round-the-clock caregivers.
And that's expensive.
Oh, my goodness. What was it? $5,000 a month? I don't know. $5,000, $10,000 a month. I don't know, whatever it was. It was 24 care. We had 3 shifts a day. People came in, and the money was burning, but I didn't want it. You know, you earned it. You know, I wanted, and we were able to hit the just about right. But it was very expensive having in-home care. And if it's coming from a family member, well, you can kiss your job goodbye or kiss your spouse goodbye if you're lucky enough to have someone. Well,
and this house meets the needs of people like that. You know, for instance, you got a person who's sick, but they don't have any family living with them.
Can you imagine? You have no family?
Right. Or you've got family, but they're all around the United States or out, and they'd have to quit their jobs. Like
right, they got kids and jobs and mortgages. Yeah, what are they going to do?
Their spouse is elderly and sick as well.
And sick, yeah.
And sometimes they're sicker than the person dying.
Right.
You know?
Right.
Or the homeless people. Or you look at moms who are losing a baby. Some of them don't want them dying at home either, because they don't want that to be the memory of the younger kids to know that their brother or sister died in their home.
So you have kids with terminal illness.
Sure. Now, we've been lucky. We haven't had any yet. But when I did palliative care, we had some. And
it's inevitable.
Oh, my God.
It's inevitable.
It was so different. Taking care of I had a 3-year-old who came, and she was pretty much actively dying, but she was alert at times. And Mom and Dad just would sit there and cry.
Oh, just cry,
It was awful.
Yeah.
And so I had took the little girl with me, and I brought her out into another room so Mom and Dad could just kind of be alone for a little bit.
Get a break.
And I was talking to the little girl, and I said, "Honey, what bothers you?" She goes, "My mom and dad crying all the time. I want to die now, so they stop crying."
What profoundly honest, right? Profound honesty and insight.
Oh, it was unbelievable.
And did you share that with the parents?
I did. And I said, and I'm not sharing this so you feel guilty or anything, but I just want you to be aware of what they're hearing and what they're feeling.
That's another being in the now. They're dying and you don't have much time with your kid and you're crying because of grief, but you need to be in the now to appreciate that time, that precious time.
Of course.
Now, we have a Ronald McDonald House here in town, and they're building a beautiful new building. And
the people from our house moved into that. That had our house. They need more room, so they moved into that.
So I know the Scouts, my boys are in Scouts. I know they go there and make meals and stuff, and it's been a wonderful way to give back. So the McDonald House, that's for the
family.
The family of someone usually in a hospital. So that's a group home for family.
Yeah.
Similar idea.
And you know, when I think about what I want at the end of life, you know, everybody is so different. I remember back when I worked in the palliative care, I had one man who had a stroke, and I had another man who was on the vent and would never come off.
On the vent. So he's got a tube down his throat and the machine's breathing for him. Yeah.
They're both dying. When I asked the guy who had the stroke, and I said, "What are you going to miss the most?" And I said, "And what kind of care do you want when you're getting ready to go?" And he said, well, this is what I call my life.
Okay.
If I can't go fishing, I do not want to be alive.
As a fisherman, I understand.
I said, okay, let's start from there. So does this mean, what about, I said, if you had somebody that could go fishing with you? And he goes, no. I have my time every day that I fish alone. And that's my peace time, my meditative time, and my me time. So I said, so you're saying unless you can go out on that boat by yourself, bring that boat back, you do not want to live. He goes, exactly right.
Wow.
So I go over to the guy over here on the vent.
Yeah.
And I said to him, what do you say is your quality of life? And what kind of care you want? He said, I'd be happy being on this ventilator every day for the rest of my life in this ICU as long as I can see my kids.
Interesting.
I mean, what a difference.
So different.
So obviously, you're going to treat them different.
Sure.
We made a little kiddie pool and filled them with fishes and stuff like you see at the little carnivals for our fishing guy. And put it at the end of the room.
Did that please him?
Oh, he was so happy. It was the cutest thing ever.
I love it.
It's so fun.
I love it.
I remembered the other one. I got called by Dr. Moscato to see a patient of his. And he said to me, Doreen, I don't know what to do. This woman's from Africa. She's 16 years old and she's dying.
16.
16.
A teenager from Africa. Did she speak English?
Yes, she did. And I said, well, please tell me you did not tell this girl she's dying. He goes, yeah, I did. And she got really crazy. I said, oh, thanks a lot. Maybe if you would read up on these people before you go into the room.
Right.
So I go in there. We never talked about death or dying at all. We just talked about things she liked to do, goals she had. And interesting enough, she said, before I die, so she brought it up, not me, I want to go to the senior prom, and I want to walk across the stage when I graduate. I said, well, that's easy enough. We can do that. She goes, you can? I said, yeah, no problem. I went outside and I said, Dr. Joe, all you got to do is set this girl up for a prom and make sure she can walk across the stage when she graduates. He goes, well, you can't do that. And I said, why not?
Oh, I love your attitude.
Why not? He said, well, if she's home, it's okay. I said, she's going to be here. You said that yourself. She's never going to leave the hospital. So he goes, well, if you can do it, go ahead. But just remember, she has to be home by midnight because that's when census is taken. So I went to the dress store and they gave us a dress for her and shoes. And we got a lady to come in and do her hair and makeup. We used our photographer.
Where did you find a prom?
It was at the school, Hickman.
So she was already a student at the local high school. Mm-hmm. And you were able to did you get her a date?
She had a date.
She already had the date?
She had a date. We got her a limo.
Oh, I'm gonna cry.
Oh, it was so
beautiful.
much fun.
This is beautiful.
I just kept telling everybody, now, don't say anybody's out of the hospital because back then you could actually check out and come back. Because a lot of the chemo patients in the hospital would do that. And did she come home at midnight? No. So I was like a worried mom pacing the floor thinking, oh my God, don't come here for census yet. But she made it back shortly after, and she was just beaming. She was walking up and down the hall with a Miss America wave. So cute.
This is just beautiful.
But
Talk
how
about
easy. And I keep telling them that. You need to ask them what their goals are.
Oh, my goodness.
Every day they should have a goal. And it may be stupid.
Every day.
Every day.
This is true.
This is true. I ask.
This is true in life, Doreen.
Yes.
Every day.
Every day. Now, her goal might be somebody who doesn't sleep will take a 3-hour nap. Okay.
It's a goal. It's okay.
Or FaceTime a member of her family,
Well, I got to ask, did she last long enough to graduate?
She died 2 days later.
After she graduated?
Yep.
Now I'm going to ugly cry.
That's
This
okay.
is just.
It was so.
You can have a life well lived at 16.
Yeah. Definitely.
So she went to prom. And she graduated high school.
And you know what? We never talked about her dying, ever.
With her.
With her. Never.
We had prom to get ready for.
We did.
We had our hair to do.
We did.
We had to graduate.
Yeah.
Wow.
And then we used all the prom pictures when she died, and we put them up so everybody could see what she did in last month.
Well, that is just incredibly beautiful, Doreen. Wow. Wow. So
It's really easy to do stuff like that.
You know,
People just don't think that way.
it's interesting. There's this truism, I say, that anything is easy if you know how to do it. Right?
Well, that's true.
Right. Which
But you learn.
it's circular logic. And for you, I think you would add that you just don't take no for an answer.
Well, I don't.
You don't.
I'm not very good at taking
Well,
no.
I knew I liked you. Now I really like you. I really like you. So in Caring Hearts and Hands, you can provide comfort, communication, and you can coordinate
Definitely.
these types of things, and you're very, very good at it. And I understand when someone is in palliative care, end of life, practicing gratitude can get you moment to moment, day to day. I know that's true about a lot of things in life, being grateful for what you have.
Mm-hmm.
I understand music is valuable. Spirituality, it's interesting you said spirituality, and the doctors like the spirituality part of the care more than anything else.
That and integrative therapies, which was so weird.
And integrative therapy.
Because we provide massages for all our patients, too.
Oh, boy, I'm a big advocate. I'm a big advocate for massage. I get one every week.
Yeah. Aromatherapy.
And aromatherapy,
music.
Yeah, there you go. And it's okay to reminisce and think about the past.
Of course.
And good memories.
The other thing that's really interesting is people always question about, when are you going to die? And
right.
I said, well, you need to ask the person. Nobody else is going to know. But most of the time they know.
They know.
I've had people tell me I'm going to die Friday at 2 p.m., and they do.
Oof.
Yeah. And they'll say, well, I don't know. I go, what does your heart tell you? What does your heart say? In 2 weeks. And they die in 2 weeks. And then, of course, I'll tell everybody else, and they go, there's no way. You got to listen to them. You got to listen to them. They know.
Intuition is powerful. And
Yeah,
this
sure
may
is.
this may sound like a weird tangent. There's something called dead reckoning. Apparently, Lewis and Clark went all the way across the country and back. They were only off by 7 miles or something, just from dead reckoning, just to figure, hey, it's about 5 miles over there. And apparently, the Polynesians negotiated the Pacific Ocean. Little boats going to island. But apparently, dead reckoning is a part of, that wave is here. Apparently, we're powerful at pulling all this stuff together if we're aware. So you're saying give credence to somebody. Say, hey, come over and see Daddy because I may not be around. And say, no, Dad, you'll be fine. Mm-hmm. Listen to him.
Definitely listen to him.
We have this intuition. Wow.
I did a presentation at Fulton State Hospital.
And by the way, just for the people listening, Fulton State Hospital, Fulton is kind of in the center of the state. Mm-hmm. And they've got a big kind of prison system there. They have a psychiatric hospital there, big hospital. It's kind of a mecca for medical care for all kinds of folks there. So it's a big place, Fulton. Mm-hmm. So tell me more now that I've introduced it.
Well, I did a presentation on how to work with people at the end of life. And one of the things I said to them was, if a patient says something, you got to really listen to it. And then see if you can figure out where that fits in with what's happening to them or what's going to happen to them or whatever. Uh-huh. But I said, you need to believe them. People in this state, they don't lie. They don't lie.
Yeah, there's a frankness here that is refreshing when you come from other places.
So one of the things they said was, I said, if a patient says they're short of breath, you need to put them on oxygen or give them morphine because that relieves some of the shortness of breath.
Okay.
Well, their response to me was, well, he can't be on oxygen because he could commit suicide. And I'm going, seriously?
Could commit suicide?
Yeah, grab the oxygen tubing around their neck.
Oh my God. Okay. That's how
seriously.
there was shoelaces and belts. Okay, I understand.
Listen to that. I said, they're dying.
Huh. Yeah, use some common sense, folks.
So you're going to take them away the oxygen so they do die.
So they do that.
But the things people say just amazes me.
Institutionalized thinking. Oh, my goodness.
Yeah, it's really funny.
Wow. Wow, I'm learning so much, Doreen. Now, is there anything else about your program you would like people to know? If there's only 2 people, how do you get a spot if somebody is...
You're on a waiting list.
You're waiting. Okay, so it's a waiting list.
Mm-hmm. The other thing is we take people in the last 30 days of life.
Well,
now,
how do you know?
Well, it's a guess.
Anticipate. This is helpful.
Yeah, it's a guess.
So you anticipate there's about a month.
Mm-hmm.
Okay. That's helpful. Okay.
Right. And other end-of-life care homes like that, some do 6 months. But for only having two guests in our home, you can only serve 48 people.
Right.
Well, we don't want to do that. We can serve more if we take the last 30 days.
Well, 40. Well, wait a minute. If it's a month, I'm doing the rough math. That would be 24. If there's 2 people, 1 a month. Mm-hmm. That would be 12 plus 12. That would be 24. Okay.
Right. Yep,
okay.
Right.
That's not a lot.
No. So we really wanted to try to serve more.
Okay.
And really, honestly, unless they've come up with a chronic disease that hasn't, disabled them from so many stuff and the family's working for a long, long time.
Okay.
It's usually in that last month that they have the most problems.
Okay.
Symptom-wise and spiritual-wise.
Yeah.
And emotionally.
So these caregivers, they've obviously had some training in.
We provide an orientation training on, what kind of meds you would give.
So if someone wants to come work for you, most of the positions are volunteer.
Yes.
But there's a few paid positions on weekends and nights. Mm-hmm. You'll provide some training if they need it. Mm-hmm. How long does that take? A month?
Yeah.
Few sessions?
Just think about this right now.
Okay.
You're at home and you have hospice. Did you get any training?
Oh, it's like a seat of the pants thing. Yeah, just have some common sense, right?
That's exactly right. Well, what we're doing for that patient is the same thing.
Right.
Help them go to the bathroom, cooking meals for them, changing their bag, and hospice gives them the showers, so we don't even have to do that. Just communication is a big thing that you do there.
Okay. Do you do some kind of background check? All right.
Yep.
So do a case night or whatever what you do. Okay. So you can't be a violent felon or something like that.
No, absolutely not. And we don't really. Probably half our staff are nurses, only because Jackie and I are both nurses. I don't know anybody that's not a nurse. All my friends are nurses.
Yeah, that happens. That happens.
You're just stuck in this mold, and these are the only people you ever communicate with. So, a lot of my retired friends are there, but they're not a nurse there. They're a caregiver. They're not a nurse.
They put on the caregiver hat.
I don't want enlisted as a nurse because they're not a nurse.
Now, do you do any paid nursing now, or are you retired? Personally,
I retired.
So this is a retirement project for you.
Well, let's put it this way. A year after I retired, I told my husband, I either got to go back to work or I got to find a big project because I'm bored silly.
Yeah.
So he said, well, don't go back to work. He's sorry he said that because I spent 16 hours a day there for years trying to get this thing going.
Yeah, people say, I want to retire at the beach. I could spend about 2 weeks on a beach.
Yeah, that's about it.
That's about it. Yeah, I want to do something with my time, something productive, meaningful.
And I love it because I can do now the things that I didn't have time to do before, back rubs and soaking their feet.
Yeah.
Doing their hair, doing their nails.
Oh, that's beautiful.
It's the fun stuff, holding their hand, watching a TV show.
So as we wind this down, Doreen, where do you see this going? Do you see yourself getting bigger and being able to have more guests?
Well, I am hoping so. Problem we're going to have is where can we do this? Right now, it's only 2 people we can have. So where do we have to build to have more than 2 people is the problem. So we got to figure that out.
Okay.
That was our biggest issue here when we went to the zoning commission. Where can we have this house? Well, being they don't understand, number one, what this house is about.
Well, how do they zone you? How do they characterize
They kept saying,
it?
well, we don't know because you don't exist. I said, well, yes, we do exist.
I do exist.
We have a house we can take you to. We exist. Just because you guys have never had it, well, then make it. Now, at Claire House in Oklahoma, they kind of work under like the public health.
Okay.
And they're just considered end-of-life home.
And there is a category. There is a checkbox or something where you can.
But now they have
fit
10
in somewhere.
beds, and they don't care. But Missouri cares for some reason.
Yeah, every state's different. It's amazing how different
Yeah, so you
states
can't
are.
go by anybody else's state
For your
because
own
rules
state.
and regulations are always different.
Yeah, it's true. In whatever state I want to work in, it's a different medical license, different rules, different boards, all that kind of stuff.
Definitely.
Yeah. So very good. So, Doreen, I have learned so much from you.
Well, I'm glad.
I've got to touch on some really important topics here that are near and dear to my heart. I'll say again, hospice care was very valuable and meaningful for my parents' last times on earth.
Definitely.
And I know there was great comfort there that was supplied during a tough time. What a pleasure talking to you about your project. I wish you many years of success. You're
Thank
clearly making the world a better place, one person at a time. And hopefully there'll be the resources, benefactors, whatever, to help your
Keep
small
open.
program to stay open and keep growing and continue to do the good work that you do.
Thank you.
Well, Doreen, thank you so much for your time. What a pleasure.
You're welcome. It's nice talking with you. You're invited to our Lights of Love this year.
Thank you.